Be prepared for tomorrow.
And golf may not fully grasp that, but there's a certain phrase they have for golfing from the women's team, not getting it past the women's team. We'll let that go. Ooh, wrong one. Making sure my microphone is on. I don't think it is. That's a pretty picture. Come on. It wasn't connected. All right. So the two primary airways we're going to talk about are oropharyngeal and nasopharyngeal. Oropharyngeal, OPAs, come in multiple types. The two primary ones that you want to be able to identify are what is known as the Goodell and the Berman. The Goodell happens to be a hollow, and then it has an inner passageway. The Berman looks like an I-beam, and then it has structurally no inner channel. There's also one called a Safar that you'll rarely see, but the Goodell and the Berman are really the two basic ones that we end up having. We want to measure them such that the idea being is I'm going to pull the tongue off the posterior pharynx so that you end up having a passageway that'll keep the airway patent. A couple different ways to size it. One is to look from the basically the front of the teeth to the angle of the jaw. Simply put, corner of the mouth, tip of the ear, center of the jaw, angle of the jaw. So whichever distance you choose, they're basically the same amount that you're looking at as far as the distance. Just as a review of some ear structures, we will do this for the nasal airway also. Ear lobe, the helix, and the tragus is this funny part right on the end there, as far as the components of the. Why don't we care about the ear? We're talking about airway. Measuring it, you'll end up being. So from the earlobe to the corner of the mouth, center of the jaw, angle of the jaw. When properly placed, it'll end up pulling that tongue up and off of the back of the throat, thereby maintaining patency. A couple of components. There's three components to the OPA. There's a flange at the very end, which prevents it from going directly entirely into the mouth, hopefully keeping it at the point of the teeth. The body, and there's an inner channel. The channel on the I-beam, the Berman airway, is not something that really anything can pass through. A lot of people have this mistaken assumption that you can pass the suction catheter through the Goodell airway. You can't. This doesn't work that way. Just basically to pull the tongue off the back of the throat and maintain patency. So flange, the body, and again the inner channel that is there. Using what's called the scissor technique, or the cross fingers, basically like snapping your fingers, With the finger you snap up on the top teeth, the thumb on the bottom, and using the strength of your thumb to open up the airway. You're going to insert the airway from a 90 degrees from where it'll end up being placed. So you're going to make a turn. You're going to insert the airway to the base of the tongue and then rotate it into place. When properly placed, again, as shown in C, you'll end up having that pulling the tongue off the pharynx. As far as maintenance, you just want to make sure there's not any pressure and necrosis. There can be where the airway is pushing in the tissue and actually causing some damage to it. And if that's the case, maybe a nasopharyngeal might be better. Removing it's pretty easy. The patient can spit it out and leave it out. They have an intact gag reflex. They don't need the airway. You just remove it by allowing it to passively come out, pulling it towards their chin. I have no idea what this video is now. I'm looking at this. So let's take a look. Or not. Well, maybe not. So, one of the things that a lot of clinicians, a lot of nursing personnel in the ICU, if somebody's biting on the tube, they'll use a oropharyngeal airway as a bite block. They'll use it to prevent the tube being compressed by the patient's teeth. That's cruel. That's punishment. This will make a gag. Oropharyngeal airway should not be used if the patient has an intact gag reflex. And I've seen clinical situations where patients, so they give them some propofol, they give them some medication to knock them out. Take the airway out. They don't need the airway. If they're biting on the tube, there's other things called novelty bite blocks that basically are rigid plastic that you can put around the tube, or looks like a donut you could put it through, so if the patient bites, they don't bite the tube. Don't use an oropharyngeal airway for that purpose. It's just mean. So nasopharyngeal airway. So again, the contraindication for an oropharyngeal airway is anyone who has an intact gag reflex. They're able to gag. Or oral facial trauma. So if somebody has kissed the steering wheel and they have Buick written across their lips, probably not a good idea to use an oral medium. Nasopharyngeal airway, the NPA, is a little bit different, and it has the same basic three components: the flange, the bevel, and in a intact intercannula, or basically a passageway through which we can put it. It's also known as a nasal trumpet. I don't know why, but it is. It's measured in French sizing, looking at the external diameter. We use it to, again, pull the tongue off the posterior pharynx. This airway, however, can be used in somebody who's conscious, somebody who has an intact gag reflex. We can use it, and again, we can do this with the oropharyngeal airway also. We can use it as an adjunct to bag valve mask ventilation to keep the airway, help us keep the airway open. More, we use this for nasotracheal suctioning. So somebody who basically has to have has to have their posterior pharynx or their trachea cleared of secretions, we can pass a suction catheter through here. In a lot of patients, maybe with oral maxillary surgery, so somebody who's got their jaw wired shut because they had some surgery on it, got a lot of secretions in the back of the throat, put one of these in, I can suction through it rather than ramming a suction catheter down their nose each and every time. To measure the size, we look from tip of the nose to the tragus of the ear or to the earlobe, so basically that distance. That distance, I guess, would be. Also looking at the diameter to make sure the diameter is appropriate size. They kind of go hand in hand. So we're looking for tip of the nose to the earlobe or tip of the nose to the meatus, which is this area just beyond the tragus. We're going to use some water-soluble lubricant. Obviously not using any petroleum products, because petroleum products will potentially cause a lipoid pneumonia, which is lethal. You can use some anesthetic spray. Usually you don't need it. We're going to go ahead and put them into the sniffing position, where the neck is hyperextended. We're going to basically pass it through the nasal cavity towards the back of the throat. It helps to expose the nasal cavity by pulling the nose back, the big nose, and then going ahead and just placing it. Some people say that you should put the bevel towards the septum. Okay, that's fine, but you got to rotate it to the opposite mirror at some point along the line. So, and we're going to go ahead and visualize it being placed. There's our big nose. Disgusting, isn't it? There is a topical anesthetic called benzocaine or lidocaine. For right now, just recognize that there's something we can do to anesthetize the area. There's lots of problems with it, and I'll let Lori talk more about it when we talk about innovation. One of the big problems is that if you use too much, you can actually cause methemoglobinemia, which obviously would not be a good idea. I have a lot of methemoglobin around. So again, we're going ahead and inserting it. People have this misperception that the nose runs back towards the head, top of the head. It actually runs perpendicular to the face. So if you go and you make that pig nose, you're just going to follow it straight down, not towards the back of the head. And when properly placed, you should see it just beyond the tongue. In fact, if you have the patient open their mouth, you should see it just beyond the uvula. Contraindications, some trauma. Patients with nasal passageway problems, polyps, deviated septum. Usually, if you just use a little bit of a rotation while you're inserting it, you can end up doing that without any problem. They don't really have smaller child and infant sizes. Want to make sure there's not any basilar skull fractures, so the portion of the skull where the roof of the nose would end up being, you can actually put it through. There's damage there, so you end up putting it into the brain tissue. So it would not be a good idea. And again, no bleeding disorders is a relative contraindication. Complications, yeah, you can cause some nasal bleeding. Usually it's not as much of a problem if using lubricant. You don't want it to go, if you don't choose the size correctly, you can actually cause the epiglottis to begin to be stimulated, and which will lead to some coughing and potentially laryngospasm. You can get some damage to nasal turbinates, and you can lead to some sinus issues if left in for a long time. Again, we're going to track this while we're doing oxygen rounds. We want to change it really every 24 hours and rotate it from side to side as needed. Removing it's pretty easy. Just pull it out. Pretty much done with that. Well, again, why do we use water soluble instead of petroleum? Because there's you can end up having severe complications from the petroleum product. Let's skip through these. Something's just wrong about that. Should at least give her a beer, right? And I'm going to stop there. We'll pick up suctioning.